Okay, thank you for the kind introduction. Yes, Glymphatics and SIA, why does that matter? Um, well, let's begin with the original description from Michael Nedergaard. You know, the glymphatic system is a para-arterial influx of CSF, then a connection to the interstitial fluid by aquaporin 4 channels located in astrocytic end feet, and then a flow through the brain and a venous outflow again. So simply spoken, it is just a CSF flow through the brain. We can have serial gadolinium cysternography at different point of times after injection to see this CSF flow through the brain. These are relaxation, T1 relaxation time maps, difference between pre and post contrast. And you see there is a difference in the basal subarachnoid cisterns and then in the parasitical CSF. So we can show that CSF flow through the brain. And the first who did that was Eide and Ringstad, a neurosurgeon and a neuroradiologist from Oslo, Norway. And we tried to replicate that, but we could not replicate it in the uh, the first patients. And we included all patients in which we did intrathecal gadolinium application. So there were patients who had no leaks, there were patients who had idiopathic intracranial hypertension, and there were patients with spinal CSF leaks. These are the contrast, a patient with 2 leaks at the tegment tympani and as a cruciform plate, similar to that what Peter Kranz showed us before. That is a hypertension IIH patient. And here we have a SIA patient with a CSF venous fistula. So putting all these patients together did not give any results. So we said we have to separate the patients with SIH from those with no leaks or IIH. And then you see at the basal cisterns, there's a signal drop. The T1 relaxation time decreases. And then it goes through the brain and it makes a difference whether the patient have SIH or whether they have no SIH. So that means the original description by Nedergaard says the arterial pulsation drives the CSF into the brain. It's not only a matter of the arterial pulsations, it's also a matter of the CSF pressure, the intracranial CSF pressure. And this is interesting because we know that the glymphatic system is more active during sleep. But one reason why it is more active during sleep is because the CSF pressure intracranial is higher when lying down. That is not the only reason, because recently Michael Nedergaard showed that the vasomotion, the power that pumps the CSF into the parietal spaces is also different between sleep and non-sleep. So that's not only the reason that we are lying down, that we have a better glymphatic transport during sleep. So the CSF inflow, in summary, is influenced by different things: cardiac pulsations, respiration, that is what we use for detection of CSF venous fistula, posture and gravity. We know when lying down it's higher, but we also know that's higher in chronic obstructive lung disease, in sleep apnea, and what we have learned from the study, CSF pressure makes a role. But what is about the venous outflow? Can we image that? We know the venous outflow is from CSF in arachnoid granulations in the venous system. And there is a second way which is relevant for the glymphatic system, that is in lymphatics. And these lymphatics are either located in the parasagittal dura or in the nasal mucosa. That is a schematic illustration, the CSF in the parasagittal dura. That was recent paper or a former paper from Maria Absinta, which used a flare after gadolinium to show that tiny lymphatic vessels. We tried to replicate it, but we could not really replicate it. And we say, okay, we have a better imaging modality that is gadolinium cysternography. These are the schematic drawing, and that's what we can show. We have the nasal mucosa. We can have signal intensity time curves in the nasal mucosa and in the parasagittal dura. But what you see on these images is also interesting. You have the arachnid granulations. So you have not to measure in that granulations, but in the parasagittal dura itself. I'm showing these images because years ago I asked Jürgen Beck and also our anatomist to show me the spinal granulations. We see them intracranially, but we don't see them in the spine. That is an illustration by Peter Franz years ago, arachnoid granulations. Why don't we see them on imaging with high resolution imaging? Maybe the reason is that they are different on a spinal level. Here we have clear cut, at 8 millimeter large arachnoid granulations. In the spine, we have arachnoid villi that are interconnected with the veins, so small that we likely can't see them. Okay, so we took care that we did not measure the signal intensity in the arachnoid granulations, but in the parasagittal dura. And then you can see that there is a signal increase related to the signal in the vitreous bodies of the eyes. So this is clearly a lymphatic transport into the parasagittal dura and into the nasal mucosa. These are the signal intensity time curves. To make the story short, there is a difference in the nasal mucosa and in the parasagittal dura. The parasagittal dura occurs a lot later than the CSF drainage in the nasal mucosa. Some words to the DTI along the perivascular space index. We have tried to replicate these findings. The idea behind is that the glymphatic transport perpendicular to the association fibers displayed in green is lower. We have, I think, a strong physics department. No one could replicate it. So here, we signal intensity measurement here and a complex formula, we could not replicate it. So we have a similar method, and this similar method is maybe superior to the DTI ALPS index. This we decompose the diffusion signals in 3 components. One component is a very short diffusion distance, and this is only possible in the neurons or along the neurons. The second one represents the axons, represents the neurons as a neuropil, and the third component represents the free interstitial fluid. And we have applied this method for several diseases. For example, here in COVID patients who have neurological symptoms after the acute phase, and we can show there is a water increase, an increase of the interstitial fluid in this patient. We also can combine that with ultrastructural histological findings here in a patient with temporal lobe epilepsy and anterior temporal lobe blurring. Of course, the next step is to show that in patients with spinal CSF leaks before and after treatment. That is not an easy task because probably related also to partial volume effects. But what you can see from this image is in the hippocampus, where we have the strongest effects, there is a difference pre and post, and pre and compared to healthy controls. So why does that is interesting for us? Well, we want to understand that brain fog associated with SIH. Um, Only a few patients have really spinal dementia that need such activities of daily living. They are handicapped. Most of them have a mild cognitive impairment, we could say that. And it is unlikely that you can solve that just from the CSF perspective or from the venous distension or whatever. It may be that is related to what parts of the brain are displaced. That is my favorite impression at this time. So we have that many patients with opacity, and that is probably related to the suction of the frontoorbital portions and to the suction of the hippocampal head. But we haven't understood. We have some patients who have apathy. We have a lot of patients who are logorrhoic, who have a disinhibition. You can go into the patient and you see, you know that he has hypertension. And if you have, it takes 30 seconds to find out that this is a clear patient with disinhibition. But we want to find out it's maybe just macroscopically related to the deformation of the brain, but it also could be related here, spinal MCA patients, just to that interstitial lymphatic fluid transport or glymphatic transport. So the summary at this point is not complete. It just shows with different MI sequences, gadolinium cysternography, T1 relaxometry, a high-resolution comprehensive black blood space sequence, and diffusion microstructure imager, that there is the CSF flow lower in patients with SIH. Thank you for listening to me.